Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology, and we are now on week 14. We are covering the last three chapters in our textbook this week, chapters 42, 43, and 46. If you are looking at your syllabus, you'll see that we are still on unit objectives 9.3.1, 9.3.2, 9.4.1, and 9.4.2. All right, so if you want to follow along in your book, let's start on page 211. What we're going to cover this week as we talk through this PowerPoint are drugs that affect the upper GI tract, specifically ulcers, motility, and obesity, and drugs that affect the lower GI tract, diarrhea, constipation, and irritable bowel disease. Then we're going to move into talking about non-narcotic analgesics and anti-inflammatory drugs. We're going to specifically look at NSAIDs, or non-steroidal anti-inflammatory drugs, aspirin, acetaminophen, arthritis, anti-gout drugs, and headaches, like headache and migraine drugs. And then we're going to finish up talking about toxicology and poisoning as well as antidotes. So let's get started. I included this in here because sometimes we have the question, what is the upper GI tract and how is it different from the lower GI tract? Even though this visual is not necessarily the one we're going to go into detail on when it comes to gastrointestinal bleeding, it is helpful to know that the duodenum, which is the first part of the small intestine, and upwards are considered the upper GI tract. And when you're talking about the lower GI tract, you're picking up with the jejunum, which is the second part of the small intestine, and following it through to the rectum. The interesting part I want to point out to you here, other than the fact that you need to know the upper GI tract and what it is versus the lower GI tract and what it is that you'll see we're going to talk about ulcers in the stomach. That is definitely where you could see an example of gastrointestinal bleeding. Same thing with the duodenum. In the lower GI tract, we're going to talk about inflammatory bowel disease. And so you'll see that in the jejunum, the ileum, and the colon. So just wanted to point out that those all involve gastrointestinal bleeding, and those are different between the upper GI and the lower GI. Typically with the upper GI, when you have gastrointestinal bleeding, the patient's stools are dark and tarry, and it's called melena. When it's with lower GI bleeding, jejunum, ileum, and colon, the stool tends to be bright red and bloody. And so that's why sometimes they can tell just from looking at the stool whether it's an upper GI bleed or a lower GI bleed. But since we're going to talk about ulcers and inflammatory bowel disease, it kind of has a purpose. All right, what is a stomach ulcer? A stomach ulcer is a small hole or erosion that occurs in the lining of the stomach. They can form also in the first part of your small intestine. They may also be called a peptic ulcer. And what causes these types of things? Well, excessive acid production, excessive alcohol consumption, which also stimulates acid production, infection. If you've ever heard of H. pylori or Helicobacter pylori, that is a common stomach bacteria that can get out of control, and that can also cause ulcers. Taking NSAIDs too much or too long can cause ulcers. Other conditions such as liver disease, Crohn's disease, or Zollinger-Ellison syndrome can also cause ulcers, as can physical stress such as major surgery or burns. Everyday emotional stress doesn't appear to cause ulcers but can make the pain worse. And the risk of getting an ulcer is increased in people who smoke and drink lots of coffee because those stimulate acid production in the stomach. How is a stomach ulcer treated? Well, if it's an H. pylori infection, there's definitely some antibiotics, usually 2 or 3, that are taken in combination together for a couple of weeks. Sometimes H2 receptor blockers that reduce stomach acid are prescribed, and we studied H2 receptor blockers last week when we talked about histamine and antihistamines. Remember that? So using an H2 Antihistamine would be something that would help with reducing stomach acid production. Proton pump inhibitors block stomach acid production. That's why so many people take drugs such as omeprazole or some type of other prazole, as you can see here. There are protectants that coat the ulcer and protect it against acid and enzymes to enhance healing, and that's sucralfate and bismuth. If you've ever taken milk of magnesia, that's bismuth, and that may help protect the lining and kill the bacteria. And obviously, if NSAIDs have been a culprit in causing the stomach ulcer, you probably have to stop taking those. And this just gives you at the bottom some ways to prevent stomach ulcers from developing. So avoid tobacco, limit alcohol, avoid NSAIDs if that's the cause of a stomach ulcer, eat a well-balanced, healthy diet, avoid late-night snacks or overeating, and reduce stress. Moving on to GI motility disorders. These occur when the nerves and muscles in the GI tract aren't working correctly, causing abnormal contractions or increased sensitivity. A person can be born with a motility disorder, or it can develop later in life, often after chronic inflammation or an infection happens in the GI tract. A motility disorder can occur anywhere within the GI tract, from the esophagus to the rectum. So typically they try and diagnose where that's happening. They look at the upper GI motility disorders involving esophagus, stomach, or upper part of the small intestine, and then they try and pinpoint it if it's in the lower GI, in the small intestine, colon, large intestine, or rectum. So what are some of these motility disorder symptoms? Well, constipation, chronic diarrhea, difficulty or pain swallowing, heartburn, acid reflux, unexplained chest pain, abdominal fullness, swollen stomach, gas, bloating, burping, pain or discomfort in the abdomen or anus, unexplained nausea or vomiting, involuntary leakage of stool, mucus discharge from the anus, pain or bleeding when passing stools. These might all be indications of a GI motility disorder. Drugs that are used to manage this include cholinergic agonists, prokinetic agents, opioid antagonists, because remember, if it's a chronic diarrhea issue, opioids cause constipation, so they are often used for that, and we'll talk a little bit more about that. And then there's antidiarrheals and antibiotics. But the agents that are most useful in the treatment of these disorders are neostigmine, bethanechol, metoclopramide, and cisapride, and loperamide. So we'll talk a little bit more about those later. Obesity. This is something that affects 650 to 700 million people worldwide. The biggest problem lies in the fact that long-term weight loss is extremely difficult, even with proper diet and exercise. This is because hormones often act against people with obesity, increasing appetite and lowering metabolism. So when it comes to treating obesity, typically there's focus on hormones. But there are also some medications that have been approved by the FDA. And we're really only going to talk about one of those because the others have a hormonal component. We've already talked about hormones. And so what we're really doing here is talking about the ones that involve the GI tract. And that would be orlistat. It blocks the absorption of up to 1/3 of the fat in each meal. So that's the only non-hormonal one. So let's go back and talk about the upper GI tract and drugs. They are designed to treat stomach and duodenal ulcers. They fall into basically 3 categories: reduced stomach acid, protectants, and neutralized stomach acid. So let's talk about reducing stomach acid. This is your proton pump inhibitors like omeprazole, like Prilosec, Prevacid, Protonix, and Nexium. So what I really want you to know here is this: when it comes to stomach and duodenal ulcers, there are 3 types. One is to reduce stomach acid, one is to be a protectant, and the next one is to neutralize stomach acid. And under reduced stomach acid, I want you to know the brand names: Prilosec, Prevacid, Protonix, Nexium. When it comes to the protectants, you have sucralfate and bismuth subsalicylate. I can't spit that one out. Sorry, carafate and bismuth. So please make sure you know protectants are carafate and bismuth. When it comes to neutralizing stomach acid, that's where you run into the antacids like Alka-Seltzer, Maalox, Mylanta, Rolaids, and Tums, and those are all brand names. So make sure you memorize the brand names and you know what they are and what they do. Moving on to motility disorders. There are two types of drugs that are designed to treat motility disorders. One is dopamine receptor blockers like metoclopramide, also known as Reglan. Again, I want you to know Reglan. Cholinesterase inhibitors like neostigmine are also used for reversing anesthesia, myasthenia gravis, and urinary retention. So what I need you to know under motility disorders are Reglan and neostigmine. You don't necessarily have to know that they're a dopamine receptor blocker or a cholinesterase inhibitor. Just know that those are the two that are used for motility disorders in the upper GI tract. When it comes to obesity, there's a gastric lipase inhibitor called Orlistat. You may know it by the brand names of Ally and Xenical. I'm looking for the brand names of Ally and Xenical, although I do think it's good to know the generic of Orlistat. So quick quiz questions. What organs are included in the upper GI tract? What organs are included in the lower GI tract? What are the three main conditions that upper GI tract drugs treat? What types of drugs reduce stomach acid? What type of drugs reduce stomach acid? What are some of the generic and brand names of these drugs? What are the brand names of both protectant drugs? What type of drugs neutralize stomach acid? And what are some of the brand names of these drugs? What drugs are used to treat motility disorders? And what are the generic and brand names of the drug used to treat obesity? Moving on to the lower GI tract, we're going to start talking about constipation and then move into diarrhea before we talk about irritable bowel disease. So when it comes to constipation, there are drugs that promote the evacuation of the bowels. They are either laxatives or purgatives. Laxatives are the milder ones. Purgatives or cathartics are the stronger action ones. So when we're talking about these drugs, they really fall into four categories. There's bulk forming, stool softener, stimulant purgatives, and osmotic purgatives, which you can really just put in the whole category of purgatives. So bulk forming would be you're trying to add that fiber, the dietary fiber, to push the stool through, and you get into bran, psyllium, and those are probably the two major ones. Stool softeners, you can get into liquid paraffin. Purgatives, that's where you're starting to talk about some of these others, and same thing with that below. So let's move on. Over-the-counter medications for diarrhea. Diarrhea is defined as 3 or more loose or watery stools a day. Typically, it's caused by infection, although there are some non-infectious etiologies, especially when you're talking about chronic diarrhea. And there are different drugs that are used for these. And so I just really have this here as information for you. Irritable bowel disease, when you look at the level of bowel disease, that's where you get into what are the drugs used. So if you're talking about mild irritable bowel disease that seems to be responsive, typically you're looking at topical corticosteroids, antibiotics, and aminosalicylates. As you move into the more moderate category where it's not as responsive, you might see immunomodulators and oral corticosteroids being prescribed. When you get to severe irritable bowel disease that is refractory, meaning it's not responsive to therapy whatsoever, that's where you end up with the surgery biologics. So let's take a look. If you look over to the right side, you'll see different drugs under there. You probably recognize under corticosteroids, prednisone and hydrocortisone. Under immunomodulators, you probably recognize methotrexate because we've studied all those. Antibiotics, we certainly studied ciprofloxacin, and so those should all be familiar to you. Irritable bowel disease typically comes in two different forms. And remember, IBD is an immune-mediated chronic intestinal condition, meaning it's an autoimmune body attacking itself situation. There's two major types. One is ulcerative colitis, and the other is Crohn's disease. If you look at our image here on the screen, on the left is Crohn's disease, and on the right is ulcerative colitis. And these are the different versions. So, for instance, you may see where it's red or pink, where it's affecting the patient. Okay, so lower GI tract drugs. The drugs used to treat constipation, which is most often caused by a lack of fiber or lack of fluid in the diet. Patients may not be drinking enough water. Maybe they're drinking too many other kinds of beverages and not enough water. Maybe they're not getting enough fiber in their diet. So that's a frequent cause, and usually a first-line treatment is to address the lack of fiber or lack of fluid. However, constipation may also be caused by slow movement or a slow-moving bowel due to disease, drugs, hormones, or trauma. It can also be hereditary. Just FYI, it can also be hereditary. Bulk forming. So the different types that you're going to see us talk about here, there's four: bulk forming, stool softeners, laxatives, and purgatives. Bulk forming means psyllium, like in Metamucil. It can also mean Fibercon and Citracel. So please make sure you know Metamucil, Fibercon, and Citracel. Next is a stool softener, and the most frequently used is Colace. So you'll see an order for Colace for perhaps a nursing home patient, that type of thing. Laxatives, you may hear about Fleet's enema or Fleet's suppository using mineral oil or glycerin. You may hear about milk of magnesia, magnesium hydroxide. You may also hear about polyethylene glycol known as Miralax. So make sure you're familiar with Fleet's enema or suppository, milk of magnesia, or Miralax when it comes to laxatives. When it comes to purgatives, make sure you know about Dulcolax and Senokot. Chronic constipation. So let me stop here for a second. Up until this point, we have talked about constipation being treated by bulk forming, stool softeners, laxatives, and purgatives. Although some of these can be prescription, many of them are over the counter. But when it comes to chronic constipation, that is almost always treated with prescription drugs. And then I've listed for you the generic names. You won't need to know that. What I want you to know is that chronic constipation is treated with prescription drugs. That's the means. They don't even use over-the-counter ones when it comes to chronic constipation because they've already tried them and they haven't worked. Drugs used to treat diarrhea. These are all the drugs that are used to treat diarrhea are opioid derivatives that have been approved by the FDA. So make sure you know that drugs that are used to treat diarrhea are opioid derivatives. Because remember, one of the biggest side effects of an opioid is constipation. So if you give someone an opioid derivative, it dries that up. It pulls that fluid out. Diarrhea is most often caused by infection, toxins, or drugs. And that's the acute kind. Chronic diarrhea is usually mild, and dietary modification is the first line of treatment. But when you're dealing with acute diarrhea, that you're usually looking into infection, toxins, or drugs as the cause. So what are some of the drugs that are available? You've probably heard of Imodium. That is an over-the-counter anti-diarrheal. It is an opioid derivative, but it is not habit-forming. An example of a habit-forming anti-diarrheal that is also an opioid derivative is Lomotil, and that's a prescription one. So please make sure that you've looked at these. And again, going back to irritable bowel syndrome, patients have constipation and diarrhea. And so some of these drugs are used to treat that, but they're also on the list that we saw earlier. And I'm not going to go into detail on your quiz about irritable bowel drugs. So what are some causes of constipation? What are some causes of diarrhea? What are the 4 types of drugs used to treat constipation? True or false? Most of the drugs used to treat acute or subacute constipation are over the counter. List the brand names of the over-the-counter drugs used to treat constipation. How is chronic diarrhea usually treated? What is the derivative of diarrhea drugs? Why do you need to know this when it comes to over-the-counter versus prescription diarrhea meds? And list the brand names of the drugs used to treat diarrhea. All right, strategies for pain management. Now we're moving into non-narcotic analgesics and anti-inflammatory drugs. So let's talk about pain management. If you will remember, when we started talking about pain, we talked about the fact that when it came to opioids, they didn't take the pain away. They simply took the nerve signals that sent that sign away. So patients could no longer sense the pain. It wasn't that they still weren't feeling that they still weren't having pain, it's just they couldn't sense it. So keep that in mind as we start talking about these non-narcotic analgesics and anti-inflammatory drugs. All right, so pain is a complex phenomenon that occurs because of the transmission of stimuli from the peripheral nervous system through the spinal cord to the cerebral cortex. Pain perception is further influenced by emotions, behavior, and previous pain experiences via multiple synapses in the limbic system, frontal cortex, and thalamus. So, it's really dependent on the pain, the location of pain, the type of pain, as to what is the most effective and least side effect analgesic that should be used. So here's a visual. If you look at the bottom, you can see that if there's trauma happening in a peripheral area, local anesthetics and anti-inflammatory drugs can usually handle that pain. When the pain sensation gets up into the peripheral nerve, the only way to block the sense of pain is through local anesthetics. Not that the person still isn't experiencing pain, but they don't sense it. They don't feel it, even though it's still occurring, because you haven't fixed the trauma. Remember that? You haven't fixed the trauma. So the pain sensation's there, you're just blocking it. As it gets up into the dorsal root ganglion, going into the spinal cord, that's when you advance from local anesthetics into opioids and adrenoceptor agonists, alpha-2 adrenoceptor agonists. And then once it moves from the spinal cord up to the brain, to the cerebral cortex, the only thing that's going to stop that sensation are opioids and alpha-2, or I'm sorry, I think that was omega-2, adrenoceptor agonists. I'm doing this very late at night and I apologize for it. So let's talk about non-steroidal anti-inflammatory drugs, or NSAIDs. These are not regarded with the same apprehension as prescribed medications, and yet perhaps they should be, because more than 30 million Americans use them daily. They are used to treat fever, acute and chronic pain, and inflammatory conditions, and many of them are available over the counter, and they come with some issues. So we're going to kind of unpack this. This is a list of NSAIDs. You get the generic name on the left, brand name on the right. The ones with stars are available over the counter. The others are usually available through prescription. So let's talk about NSAIDs. When we're talking about NSAIDs for the purpose of this class, right now we're also including aspirin. They're thought to work by inhibiting prostaglandin synthesis. So make sure that you know that NSAIDs and aspirin are thought to work by inhibiting prostaglandin synthesis. Most NSAIDs, including aspirin, have analgesic, meaning to take pain away, antipyretic, to take a fever away, and anti-inflammatory effects. Now notice I underlined most. Not all do, and we're going to talk about that. And I think that's one of the biggest misconceptions that's out there, is that all NSAIDs have those effects, and that's not the case. Only most. older NSAIDs, including aspirin, also have antithrombotic effects. And that's why aspirin is often used with patients who are in the middle of a heart attack, is because they have that antithrombotic effect so that they can thin the blood and get those clots out of the way. NSAIDs, including aspirin, are used to treat moderate pain, fever, tendinitis, sunburn, headaches, migraines, rheumatoid arthritis, and osteoarthritis, among lots of other conditions. So NSAIDs, depending on what they are and what they're going to be used to treat, can treat a multitude of things. The most common adverse effects of NSAID, including aspirin, are GI or renal injury, GI upset or renal injury. So make sure you know those. The reason this is in here is because we're going to talk about aspirin. And what this is showing you is how aspirin at a regular dose and aspirin at a high dose, how they work on the prostaglandin and how they end up with different types of effects. And that's really all I want you to notice from this. Aspirin, we had information about aspirin and NSAID, so make sure that you include that mentally when you're prepping for aspirin and what it can do and not do. Aspirin in children, using aspirin in children is something that has been heavily publicized to not do because it's been associated with Reye's syndrome, and this is characterized by central nervous system damage, liver injury, and hypoglycemia. Children who, for whatever reason, reacted to aspirin and developed Reye's syndrome just have had a horrible time of it, even up to death. So there's been a lot of education, particularly in the 70s, the 1970s and 80s, about do not ever give children aspirin. I happen to have been a child in the 70s and can remember getting St. Joseph's Children's aspirin for all sorts of different things. But then I remember a time when my mom absolutely stopped that. So it's just interesting to look back now as a parent. I don't know that I even have aspirin in the house. Aspirin overdose symptoms include tinnitus, and that's the ringing in your ears, dizziness, headache, fever, and mental status changes. So if someone has taken more aspirin than they should, they may have those types of side effects. Acetaminophen, aka Tylenol. It is found in more than 600 different prescription and over-the-counter medications. Although it has been a safe and effective pain reliever and fever reducer, there's also been times where people have exceeded the maximum and it has resulted to liver damage. So we're going to talk a little bit about that. And typically the way people exceed the 4,000 milligrams per day is by taking the next dose too soon, using multiple products containing acetaminophen, or taking too much at one time. So we talked a little bit about acetaminophen and NSAIDs. However, make sure that you understand this. Acetaminophen has analgesic and antipyretic actions, but it does not have anti-inflammatory or antithrombotic effects. So if someone has told you to take Tylenol or another form of acetaminophen for an anti-inflammatory or antithrombotic reason, it's never going to work. And acetaminophen overdose excess has caused fatal liver damage, meaning people have died. And so that's why they've tried to get the word out to be careful about how many milligrams of acetaminophen is consumed a day. So quick quiz questions. True or false? Pain perception is influenced by emotion, behavior, and previous pain experiences. True or false? Pain is sensed in the peripheral nervous system and transmitted to the spinal cord before being sent to the cerebral cortex. How are NSAIDs thought to work? True or false? All NSAIDs, all, have analgesic, antipyretic, anti-inflammatory, and antithrombotic effects. True or false? The most common adverse effect of NSAIDs is liver injury. List the generic and brand names of as many NSAIDs as possible. More quick quiz questions here. True or false? NSAIDs are used for headaches and migraines. True or false? Aspirin is considered an old NSAID, and its antithrombotic effect is why it is given to patients during an AMI. I want to go back to the first one here about NSAIDs used for headaches and migraines. That is actually true. And we'll talk a little bit about that when we get to headaches and migraines, but it's here now, so I'm going to let you know that's true. Skipping back into order, number 3, what serious syndrome has been linked to children taking aspirin? What actions does acetaminophen have, and what effects does acetaminophen not have? What can too much acetaminophen cause? True or false, ibuprofen and acetaminophen are the same drug with the same effects. If you are not sure about that, please go back and research that. They are not the same drug and they do not have the same effects. Motrin and Advil and Tylenol are all different. I mean, Motrin and Advil are the same, but Tylenol is not the same. So moving on to our headache, migraine, or I'm sorry, arthritis. I'm trying to go ahead, sorry. Arthritis. This just tells you the different types of drugs that are used to treat arthritis, and it depends on the type of arthritis. So keep in mind there are different types of arthritis, but there are often painkillers used for arthritis. And as you notice, there's opioids mentioned here. We've studied those. There are NSAIDs, which we're in the middle of studying. Counter irritants. This is where you get into the topical ones that are that sink into the skin to try and relieve whatever's happening with that aching joint. You have what's called disease-modifying anti-rheumatic drugs, also known as DMARDs, and these are used for rheumatoid arthritis. So you'll want to be familiar with DMARDs. They slow or stop your immune system from attacking your joints, and they include methotrexate, which we've studied a couple of different times, and hydrochloroquine. Biologic response modifiers are another one that are used to treat rheumatoid arthritis. They're usually used with DMARDs. They target the protein molecules that are involved in the immune response, and some of those are listed there for you. You may recognize like Enbrel and Remicade. There are other ones that play a role in inflammation that have to do with the immune system here, and those are listed. Then corticosteroids, we studied those quite a bit. We studied prednisone, so that one should be familiar, as well as cortisone. And those are also used with arthritis. So let's look at arthritis drugs as it relates to osteoarthritis. This is where you have a healthy knee on the left, and I apologize that this is a bit blurry, but you have a healthy knee on the left. Notice that you've got all this, where the white is. You've got the synovial fluid, and you've got the cartilage, and all of the blue is the synovial fluid, and there, and the white are the cartilage. Okay, so you have that. In moderate osteoarthritis, you can start to see where that's been eroded away, and you're starting to get close to bone on bone. Severe osteoarthritis, you've now got those areas where it's bone on bone. There's no padding there. There's no stopping that grinding and that pain. So NSAIDs with anti-inflammatory effect, so that means ibuprofen, not acetaminophen, are the drug of choice for osteoarthritis. That's what they start with, and then they can move up from there. When it comes to rheumatoid arthritis, DMARDs are the drug of choice. And this gives an example of a hand with rheumatoid arthritis, and it shows you an enlarged picture of that joint in the finger. You can see where the synovial fluid, you've got degraded cartilage, you've got a thickened synovial membrane. You can see where it's been eroded in here, causing inflammation because of that autoimmune response, where those cells are attacking the body itself. All right, let's talk about gout, because that's another part of it. We're going to talk about anti-gout medications now. Gout is a metabolic disease in which plasma urate concentration gets increased. Uric acid is a product of purine metabolism, and when the urate level increases in the blood, it precipitates and deposits in joints, particularly in the foot, particularly in the big toe, and It's caused by over drinking of alcoholic beverages, especially beer or purine-rich foods, and we'll talk about what those are in just a minute. It can also be caused by leukemias, lymphomas, polycythemia, um, those types of conditions that are treated with chemoradiation. And it can also be caused by some drugs, and it lists those for you down there. So what are anti-gout drugs that we need to be aware of? They fall into a couple of categories, and we're going to really just focus, because we know about glucocorticoids, but we're going to focus on the ones that are listed above: allopurinol, probenecid, and colchicine. For acute gout, the drugs that are used are NSAIDs, colchicine, and glucocorticoids. When you get into chronic gout, that's where you have the repeated episodes of pain and inflammation. More than one joint may be affected. That's when you see more use of probenecid and allopurinol. So let's talk a little bit more about anti-gout drugs. Gout is the buildup of uric acid in the tissues, which then causes inflammation because leukocytes migrate to the joint in an attempt to clear away the uric acid crystals, and then you get the inflammation. So first of all, you have uric acid that builds up in the tissues. Then you have these white blood cells, these leukocytes, who rush to that joint to clear away the uric acid crystals and create all this inflammation. Acute gout is treated with colchicine, NSAIDs, and/or intra-articular glucocorticoids to address the inflammation. Chronic gout is treated with drugs that inhibit uric acid synthesis and/or increase uric acid excretion. So that's where you get into the allopurinol or the probenecid. The best way to treat gout is to avoid a high purine diet and drink cherry juice. Just so happens my grandfather had this, so this is familiar to me. High purine foods include alcoholic beverages of all types, some fish, especially seafood and shellfish. If you're thinking about crab and some of the other wonderful seafoods or shellfishes that are out there: anchovies, sardines, herring, mussels, codfish, scallops, trout, haddock. Some meats such as bacon, turkey, veal, venison, organ meats like liver, rich meats. High purine is really about rich foods. So it also includes beef, chicken, duck, pork, ham, crab, lobster, oysters, and shrimp. My grandfather loved seafood, and he also loves a really good steak and some other cuts of beef, and so like prime rib. So yeah, that was tough for him. But that is one way. Another way also is to drink cherry juice. You will often find patients who have gout, after they get past their gout flare-up, the doctor will prescribe that they drink 4 to 6 to 8 ounces of cherry juice a day, and that also keeps the uric acid from building up. So just so you know. All right, I'm finally at headaches. Hopefully you don't have one at this point in the presentation. There are a couple of different types of headaches, and what we're really going to focus on more than anything is migraine. But just to kind of show you where the type of headache is often defined by location. So a sinus headache is pain behind the brow bone and or cheekbones. Cluster headaches are known as in and around one eye. Tension headaches are typically, they feel like a band squeezing around the head. And migraines are where patients experience pain, nausea, visual changes. They're nasty, nasty pieces of work, shall we say, those migraine headaches. The next several slides, I found this great article about migraines and about what they're learning about migraines and how much it is changing through the research that's being done. For instance, here it talks about the brainstem, that the exact starting point of a migraine remains a mystery. However, many suspect it begins in or near the brainstem when overexcited brain cells or neurons fire. And then from there, they stimulate the trigeminal nerve, triggering it to release several neurotransmitters, including serotonin and neuropeptides that are believed to be the culprits behind the agony. Then you have sudden surges of serotonin that inflame blood vessels surrounding the brain, and those inflamed blood vessels irritate the nerves they're attached to and cause pain. So you then have that, like on one side of the head or the whole head where it's just misery. Then these firing neurons continue to send signals out to different parts of the brain that can lead to intense discomfort and other symptoms such as nausea, speech problems, and aura. And that's a set of neurological disturbances that can cause effects like blurred vision or seeing spots, flashes or halos, and tingling on one side of the body. And this is just a continuation of the article. It's here for you to read, especially you may find it interesting. Women are 3 times more likely to get a migraine than men. They're still not sure of the link between hormones and brain pain. Fluctuations in estrogen appear to trigger migraines. So that is why some women are more likely to get a migraine right before their period, during or after pregnancy, or during menopause. Some other common migraine triggers are not gender specific, such as alcohol, artificial sweeteners, cured meats like hot dogs and salami, foods that contain the compound tyramine, including aged cheese and some soy products and red wine, dairy, chocolate, gluten, nuts, and the MSG, the additive MSG, have also been implicated in causing migraines. I like how in this first paragraph they say, even just 10 years ago, doctors thought migraines were a blood vessel problem. Now we know they are neurological, meaning they're caused by bursts of cellular activity in the brain, and that has contributed to innovations in treatment. How cool is that they have found that? Also, weather can be an implication because some migraine sufferers are especially sensitive to changes in barometric pressure, such as right before a thunderstorm or when you're ascending in a plane. Warmer temperatures may be another trigger. They found that for every 9-degree increase in temperature, there was a 7.5% increase in severe headaches, including migraine. So, weather can obviously be another trigger. Day-to-day habits can play a role. If you don't get enough sleep or have an irregular sleep schedule, that can prompt a migraine, so can stress. And interestingly enough, I like how this doctor from Winston-Salem, North Carolina, writes that migraines are a brain condition with a very strong genetic component, that, a lot of these, the more research gets done, some of these are genetic. There's no preventing them. So let's talk about headaches and migraines. NSAIDs are usually the first line of treatment for headaches and migraines after any underlying problems are treated. So for instance, if you have a sinus headache, yes, you definitely want to consider an NSAID, but it won't help if you don't treat the underlying sinus infection or other issue that's involved. But acute migraines are usually treated with selective 5-HT1 receptor agonists known as triptans, which act on intracranial blood vessels and peripheral sensory nerve endings, resulting in vasoconstriction and decreased release of inflammatory neuropeptides. There are other drugs that are used for migraines, but they have had mixed success and/or serious side effects. So, quick quiz questions. What kind of drugs are used to treat osteoarthritis? What kind of drugs are used to treat rheumatoid arthritis? Would you use ibuprofen or acetaminophen to treat osteoarthritis, and why? What causes gout? What is acute gout treated with? Give me a drug name. And what is chronic gout treated with? I need a drug name for that too. List some high purine foods to avoid if a patient has gout. What kind of drugs are used to treat headaches and migraines at first? Would you use ibuprofen or acetaminophen to treat a migraine, and why? What kind of drug has been successful in treating acute migraines? And what are some ways migraine patients can influence or trigger their migraines? All right, we are moving on to our last chapter, chapter 46, on toxicology and poisoning. And I realize that this is a very busy slide. It's very hard to see, very hard to read. What I want to point out to you is that to get to a systems toxicology, there are multiple things that are involved. They include population responses, organism responses, tissue organ responses, cellular responses, molecular interactions, and exposure. They look at things like death rates and disease rates, impaired development, disease and lethality, altered tissues and their function and homeostasis, alterations in gene and protein expression, protein modification, metabolic levels and lipid classes, binding to macromolecules, chemical structure and properties, internal dose, metabolic transformations. Look at epidemiology, phenotypic observations, quantification of physiological and histological changes, causal computable biological network models, quantification of ligands, bindings, and adduct formation, and then population events, organism events, organ events, cellular events, and molecular initiating events. All of that goes into systems toxicology. Not that you need to know that, but I'm bringing it here just so you can see that toxicology is not a one-dimensional or even two-dimensional situation. Systems toxicology, or 21st century toxicology, aims to create a detailed understanding of the mechanisms by which biological systems respond to toxicants so that the understanding can be leveraged to assess the potential risk associated with chemicals, drugs, and consumer products. That first paragraph is probably really the most important out of all of this. The last paragraph has some interesting information too, but you can also read through this. It's not going to be on your quiz. It's there just simply for you if you are interested in it. Again, this is another visual that I put here because I want you to see what all goes into toxicology and the different levels. So I'm not going to go through all the details except to say physics, chemistry, biology, toxicology, engineering, mathematics, computer sciences, utilize enabling technologies such as the genomes, transcriptomimics, proteomics, metabiomes, lipidomes, HCS, HP computing, all these different things. And then they look at molecular measurements, the external environment, internal environment, cellular space. And then there's apical measurements of organism responses, organ responses, and cellular function. And then there's artificial intelligence and computational models such as biological networks, multi-scale models, and adverse outcome pathways. All of these are used to develop detailed mechanistic understanding of toxicity, prediction of adverse outcome, and develop a new paradigm for risk assessment so that we have safe drugs, safe foods, environmental protection, green chemistry, and ecotoxicology, as well as understand the mode of action. So all these things go into toxicology. Again, you don't need to know that detail, but I put it here just so that you can see how much goes into it. So what do you need to know about toxicology and poisonings? Toxicology is the study of the toxic or harmful effects of chemicals. Toxicology is concerned with the symptoms and treatment of poisoning and the identification of the poison. The general principles of the toxic effects of chemicals are, for the most part, the same as the principles of therapeutic effects of drugs. Intentional and accidental poisonings are major medical problems, because every natural or synthetic chemical can cause injury if the dose is high enough. This is probably the most critical. The last two bullets are probably the most critical things that you need to know off this. So again, every natural or synthetic chemical can cause injury if the dose is high enough. The most important treatment of poisoned patients is supportive care. You treat the patient, not the poison. This is because toxicology screens of blood or urine take time and rarely change the patient's therapy. And also, you've got to treat the patient. You've got to take care of them. So make sure you understand that when you're dealing with poisoned patients, the patient is treated first, not the poison, although the poison should be identified. You'll need that for coding, by the way. All right, so poisonings. To reduce the absorption of the poison, there are 3 ways to reduce it, okay? 3. The first one is induce emesis with ipecac within 1 hour of poison ingestion. The second way to reduce absorption of the poison is to use gastric lavage within 3 hours of poison ingestion. The third way to reduce absorption of the poison is to dose with activated charcoal, in most cases, which can be done after 1 hour to reduce the poison's half-life and increase its clearance. To enhance elimination, there are also 3 ways you can do this. You can give multiple doses of activated charcoal. You can increase the pH of the urine by what you give the patient, usually through infusion, and or use hemodialysis hemoperfusion to remove the poison from the blood. So you need to know there are 3 ways to reduce absorption of the poison and what they are. You need to know there's 3 ways to enhance elimination and what those 3 are. Why do we need to know about poisonings? Well, for us in HIM or HIT, it's all about coding. When you go to code, you need to know the substance, and you need to know, was it unintentional, intentional self-harm, was someone assaulted through poisoning, or is it undetermined? Or was this an adverse effect, or was it an issue of underdosing? Because you'll need those for coding. Now I want to move on to plants because I thought it was interesting. We talked about drugs, but also people can run into it with plants. And these are just some that you may not be aware of. And as we're getting into spring, rhubarb, you will start to see rhubarb pies, rhubarb sauces, rhubarb this, rhubarb that. And just it caught my eye that the leaf blade of the rhubarb is toxic. And that if you have too much of it, it can cause convulsions, a coma, followed by death. So really, again, especially if you have little children, you want to keep them away. If you have lily of the valley, irises, bleeding hearts, those types of things in your flower garden. Another way that poisonings happen in the home is because candy and drugs or juice and cleaning products look similar. And I will even give the example in my house. I've had to have the lecture with my kids a couple of times that gummy vitamins are not gummy bears. That although they may have more than 2 gummy bears, when it comes to gummy vitamins, they must limit themselves to 2, no matter how good they taste. So as you can see from this poster, there are packets and items. They look very similar, especially if they're outside of their packaging. And we just have to be really careful with people that are in the home. They are aware of what's appropriate and what's not, or what's dangerous and what's not. Also, for those of us who are women, we usually have a purse, and it has all sorts of stuff in it. And I don't know about your family, but every now and again, my daughter likes to get into my purse and see what's in there. Nothing super secret, of course, but for a child that's bored that grabs mom's purse and goes into it, there's all sorts of things in there that can be toxic to them. And this just gives you a list of those types of things like hairspray, perfume, nail polish remover, prescription medications, over-the-counter medications, nose spray, mouthwash, chocolate laxatives, hand cream, eye drops, batteries, ink pen, insect repellent, cigarettes, pepper spray, baby powder, toothpaste, all those types of things can be toxic to a child or to a pet. All right, now let's talk about antidotes. Antidotes. We talked a little bit earlier about activated charcoal, and in most cases, activated charcoal is a really good idea. However, it should never be used with phenol, corrosives, heavy metals, or hydrocarbons. Those are the examples that active charcoal does not work with and should never be used. Now, this next part will not be on your quiz, but I thought you would be interested in it. I certainly am. And definitely want to remember this in case hopefully I'll never have to use it, but it's good to know. The home remedy of activated charcoal is getting 2 parts of charcoal, usually through burnt toast, 1 part of magnesium oxide, which is milk of magnesia, and 1 part tannic acid from brewing some very, very, very strong black tea and putting it all together, and it works as activated charcoal. Copper sulfate is a poison itself, but it is used as an antidote for phosphorus poisoning. So, that's another one to kind of keep in mind. Naloxone or Narcan, we studied this back when we were studying opioids. Naloxone, and the brand name is Narcan, is the antidote for opioids. You can get it without a prescription. You can either talk to your family physician or you can call the health department. There's a couple of different ways that you can get it without a prescription to keep on hand to administer in an emergency situation if you worry about someone in your life who is on opioids. It's very easy, unfortunately, for those who are on opioids to take too many. They don't intend to. Maybe they forgot when they took their last one. Maybe they take it a little early because they've had some breakthrough pain. There's a wide variety of reasons why it happens. But with opioids, there's a very thin line between enough and too much. And that's where having Narcan on hand could possibly be a lifesaver, because Narcan or naloxone, that brings somebody right out of an opioid situation. It blocks the opioids and brings them back to consciousness. So just something for you to be aware of. All right, these are slightly blurry, and I apologize for that, but these list the poison on the left and the antidote on the right, and they're here for you to look at. Some of them are really obvious, like anticoagulants. The antidote is vitamin K or fresh frozen plasma. Carbon monoxide. The antidote is oxygen. Let's see if another one that you might be familiar with. Beta blockers. The antidote is glucagon or insulin. Insulin, the antidote is glucose. So for instance, if someone has hypoglycemia, you try and get some something with glucose in it into their system to bring up their blood sugar. With methanol, it's ethanol. With opioids, it's naloxone. So you can just see here. You don't have to memorize any of these. Sometimes the question comes up, is it an antibiotic or an antidote that you would use to treat something? When it comes to valproic acid toxicity, for instance, and valproic acid, by the way, is used to treat epilepsy, bipolar mood disorders, and prevent migraine headaches. So if someone has valproic acid toxicity, the antidote is an antibiotic, carbapenems, which we studied back in the antibiotic section. When it comes to poisonous mushrooms, that's the amatoxin mushrooms. Again, antibiotics also help. So this is just there to remind us that an antidote can sometimes be an antibiotic. So quick quiz questions. What is toxicology and what is it concerned with? True or false? Every natural or synthetic chemical can cause injury if the dose is high enough. True or false? The best way to treat poison patients is to treat the poison. What are the 3 ways to reduce absorption of a poison, and what are the 3 ways to enhance elimination of a poison? What are the categories used to code poisonings? When should activated charcoal not be used? True or false? Naloxone or Narcan can be obtained without a prescription. True or false? Naloxone or Narcan is an antidote for aspirin. True or false? Copper sulfate is a poison that is used as an antidote for phosphorus poisoning. True or false? Carbapenems, which is a type of antibiotic, is recommended as an antidote for valproic acid toxicity. And what 3 conditions is valproic acid prescribed for? If you can answer those questions, you are in good stead when it comes to this week's quiz. And that is it for our slide presentation for this week. I hope you have a great week. And next week we are moving, because we're finished with our textbook, we're moving into the topic of drug identification. So I'll have a lecture video for you, you'll have your discussion, and then we'll have our weekly quiz. Take care.